For the initial treatment of metastatic ALK-positive non-small cell lung cancer, we have several approved targeted agents, all better than chemotherapy. First was crizotinib, but over the past few years, we've added ceritinib, alectinib, and most recently, brigatinib. While all four are approved agents, alectinib and brigatinib really are the preferred choices in the first-line setting due to tolerability and CNS penetration. Brigatinib was initially approved in the salvage setting, just as ceritinib and alectinib were. It is notable that the progression-free survival with second-line brigatinib in the ALTA trial was 16.7 months, significantly longer than that seen in other TKIs given in a similar setting. Brigatinib was approved as first-line therapy on May 22, 2020, based on the phase 3 ALTA-1L trial. This was a large trial of 275 patients with treatment-naive ALK-positive non-small cell lung cancer that were randomized to brigatinib or crizotinib. In this study, brigatinib was clearly the superior choice with a much better progression-free survival, the PFS hazard ratio of 0.49, the response rate quite high at 79%, clearly superior than crizotinib and justified as a first-line choice with excellent penetration within the brain. In fact, patients with brain metastases had particular benefit with the use of brigatinib. Brigatinib is a selective ALK inhibitor. It is designed in a rational manner where it retains activity in the setting of many solvent front mutations, which led to its high activity in the salvage setting and hopefully will lead to prolonged benefit in the frontline setting by preventing the development of resistance. Brigatinib is administered orally as one pill daily, is initially given as 90 milligrams per day for 1 week, followed by 180 milligrams daily, provided there are no issues with tolerance. When we think of choosing tyrosine kinase inhibitors for ALK-positive non-small cell lung cancer, I think the efficacy on brain metastases and duration of intracranial response is of critical importance. Brain metastases can be devastating events, and unfortunately, this can be a very unforgiving site of relapse. It is critical that the choice of agents reflect activity within the brain, and using a CNS penetrant kinase inhibitor, I think, offers a clear advantage, not just for progression-free survival and overall survival, but really for quality of life as well. Efficacy on brain must be considered in our choice of therapy. Common toxicities with brigatinib include largely laboratory elevations. While we do see elevations in CPK, lipase, and amylase, those have very little clinical consequence. In fact, off study, I don't routinely check those. These are largely paper toxicities where they were noted on the trial because they were sought. However, in someone without symptoms, they are really of unclear significance to me. Elevation in amylase and lipase in the absence of pancreatitis or symptoms of pancreatitis really has very little impact within my clinical practice, and elevation in CPK is not as concerning as someone with symptomatic cramps or myalgias. So my monitoring largely is based on liver enzymes and symptoms. Brigatinib does have a unique pulmonary toxicity. This is not really a pneumonitis, rather an impact in shortness of breath and oxygenation. By starting at 90 milligrams for 1 week before escalating to 180 milligrams, the incidence is quite low. And so it is typically our pattern to start with 90 milligrams daily. At 1 week, we check in with the patients, and provided there are no concerning symptoms, we escalate to 180 milligrams. I've personally not seen any toxicity problems by using this approach. Personally, my experience with brigatinib has been very favorable. I've used both brigatinib and alectinib in the frontline setting as my preferred agents, as both have very good CNS penetration and are well tolerated. I think one advantage of using brigatinib in the frontline setting is 1 pill per day. Alectinib is another approved and very active agent. However, at its full dose, it is 4 pills twice daily, which is quite a high pill burden for a younger, active population. It can be very easy to miss doses, forget doses. 1 pill a day does offer some advantages. When we think of how brigatinib performs in this space, it really fits the paradigm for precision oncology. Most patients respond very quickly and very well. Responses are deep and durable, and we have excellent CNS penetration. In addition, toxicity is very low, which means adherence is very high. The pharmacokinetic data performed with brigatinib does show that no relationship between exposure and certain lab abnormalities, no impact between exposure and time to dose reduction. I think if dose modifications are required for toxicity, I still feel very comfortable in terms of efficacy. In my opinion, adherence is often a surrogate for toxicity and tolerability, but adherence is also informed by convenience of dosing, and that is a clear advantage with brigatinib.